Hello everyone, this is Braswell Dean from the Providence Hospital Department of Family Medicine. This is our EKG Competency Review Part 3, our quick orientation to clinical cases. And this review, again, is designed for residents preparing for your boards, for cardiology rotations, or for our competency review exam. So I hope this is helpful to you. In part 1, we did a big review of EKG physiology. Part 2, we started looking at more and more clinical cases, and we tried to review a whole bunch of rhythms and things. And so we left off in part 2 talking about AV dissociation, and I wanted to take back up there really quick before we jump in for our formal part 3 review. So what we were doing last time was looking at AV dissociation, third degree heart block. And again, last time we said, well, you know, here's a rhythm. The ventricular rate looks pretty good. You know, you think, oh, wow, it's not too bad. But then you see all these P waves down here and you think, oh, another headache. So whenever you see a whole bunch of P waves, the name of the game is to make sure that the PR intervals are constant. And if they're constant, great. That is a sign that you have one-to-one conduction. If the PR interval is constant, then that is a sign that the atria are depolarizing. The atria is depolarizing the ventricles. Okay? If they're not constant, then something's up. They're not connected. Okay? And we call that disconnection, AV dissociation. That means the atria are depolarizing at a different rate than the ventricular rate. So let's try to prove that again, just to look at it. So we look at this QRS because it's right on a big line, and anytime it lands there, we can easily calculate the rate: 300, 150, 100, 75. A little bit faster than 75. This is going about 80. Okay. You say, oh, that must be sinus rhythm. Well, it is kind of sinus rhythm, or it's a rhythm that it's either a rhythm being conducted by the atria, or maybe it's a junctional rhythm. Maybe it's a junctional accelerated junctional rhythm. Okay, because the atria are maybe depolarizing at a faster rate. So we say, let me think. So we put our imaginary calipers from here to here, and then from here to here, and from here to here, and from here to here. And we see this thing kind of walking out all around, all down the strip. So we think, wow, that means the atria are depolarizing at their own rate. And we look for this P wave just happens to land on this line, just like this R wave landed on this line. So we calculate the same way as we did up here. 300, 150, okay? So a little bit faster than 150 is about 160. So we can easily see that the atria are going about twice as fast as the ventricles. And if that's the case, we have a case of AV dissociation. And when we look down here and we see the PR intervals, really short, really long over here, maybe a little bit shorter, but still pretty long. Short, longer, longer, short. Again, no rhyme or reason. It's not like Mobitz 1 where it gets a little bit longer and then you have a drop beat. Like that's the Mobitz 1 Winky Bach. And it's not super constant like Mobitz 2, okay, where you have fixed PR intervals, but every once in a while you're going to see 2 P's for every QRS, which is 2-to-1 conduction, or 3-to-1, or 4-to-1 conduction. Okay, it's not that. And the key to differentiating all that is the fact that in third degree block, atria and ventricles are all disassociated, and that's because the PR intervals are completely, they're like irregularly irregular PR intervals. Now, I created this illustration a long time ago, and I've been waiting to use it, so let me just show you really quickly. It's a kind of a humorous now illustration, but back when I was making it, I thought it was pretty cool. So if we could imagine a rod with a roll of toilet paper on one at the top and a roll of paper towel at the bottom, and the paper towel would be representing ventricular depolarization or some type of something that has depolarized the ventricles at some rate, either like a junctional rhythm or a true ventricular rhythm, and at the top, it would represent atria depolarization. And because you've got two different groupings here, it's disassociated. So we can pull the paper towels faster or slower than the ventricles. And I'll leave that up to you to decide how fast you need to pull the paper toilet paper. So just for the fun of it, I made this, but it just goes to show the P waves can be just clipping along at their rate, ventricles clipping along at their rate, but the final EKG pattern, puts them all on the same piece of paper, but it doesn't necessarily mean they're all beating at the same rate, okay? And that's what this is supposed to illustrate, okay? Hope you found that helpful. So now we'll jump right into the official Part 3 orientation to the clinical cases. So again, we talked about board exam points, having one main finding. The clinical case is likely included with each EKG. As we said last time, there's going to be a clinical case. Usually on your boards, it's going to be part of the question. The question is likely to focus on the clinical case as well as the EKG, so you'll probably find some hint in there. Maybe ACLS might be more prone to give you just more strips, but in any event, for boards, the clues might be in the case. But don't prepare for your boards looking for zebras. Okay? Prepare for your boards to look for the common arrhythmias, the common cardiac diagnoses, and some of the common non-cardiac EKG abnormalities. And just try to prepare for the emergent can't miss things too. And we've tried to do all of those things in this review. So if you go through Part 1, 2, and 3, it's my hope and prayer for you that you'll crush your EKG questions on the boards, and you'll just super crush any ACLS tests that you might have to have, because we put a lot of stuff in these reviews. So that being said, let's look at case number 7. A 28-year-old male presents for a commercial driver's license, no complaints, vital signs are stable, exam shows no significant findings. What do you see? Looks pretty regular, but the thing that's supposed to jump out at you here is, once again, we're highlighting the PR interval. This PR interval is really, really small, okay? Now, and they're constantly really, really small, okay? So there's sort of this 1P for every QRS, but as we said back in Part 1, a normal PR interval should be shorter than 0.2. Anything longer, we would call that a first degree AV block. But it also should be at least 3 little boxes, okay? We call that 0.12. So it should be at least 3 little boxes long, but no bigger than 1 big box, okay? Now, anything bigger than 1 big box, we said, was first degree AV block. Now, anything shorter than 0.12, and we might have that P wave, we could call that a non-conducted P wave. In other words, that P wave was depolarized by the atria, but it wasn't connected to the PR to the QRS. The interesting thing about this one is that we see this classical slurring of the QRS, and we call this WPW. This is a pre-excitation pattern. The PR interval is too short, and the delta waves are seen in the leads. Now, for this kind of a patient, you want to observe them, but they are also associated with SVT or atrial fibrillation, which means you've got an accessory pathway on your hands and you need to ablate it. So let's take a quick look and see what's happening. The normal signal is supposed to start at the SA node, and then the AV node gives this compensatory pause, okay, which is what the PR interval is. It's like the AV node is like a stoplight. It allows the blood to catch up with the electrical conduction. And then the signal goes down to the bundle of His and Purkinje fibers. But every once in a while, you can have this bypass track, and we sometimes recall this the bundle of Kent, It's a bypass track, and it allows the signal to bypass that pause that occurs in the AV node. And then you have this early activation of the ventricle, and what that does is that contributes to this slurring, that early slurring that we see in the QRS. Okay, so let's take a quick look. SA node to the AV node and normal depolarization. That results, if you look down here on the left, you see a normal P wave with a normal narrow QRS, a T. That's our normal sinus rhythm. That means that SA node depolarizes the atria and is responsible for depolarizing the ventricle. However, with WPW, that we see the example over here on the right, we will have a bypass track which will cause slurring of the QRS pattern. We'll have this delta wave. And notice that the example down below is the PR interval is so short. And that's because that bypass track has allowed ventricular depolarization to bypass the stoplight of the AV node. Now, what this one over here is illustrating on this side is when we have an accessory pathway that allows the signal to kind of come back and depolarize. And this is the association of the bypass track with atrial fibrillation and SVT. So a lot of times we'll have these WPW people who have these asymptomatic things, but we also sometimes don't see it when they originally present. Like this, the dude in our presentation was presenting for just the commercial driver's license, commercial license exam. But sometimes they present in the emergency room with tachycardia. So once that slows down, what you might see is the WPW. Okay, and it's really, so I just wanted to show you that the accessory pathway can be associated with this antegrade conduction in the asymptomatic patient, but also with this circular conduction pattern that's very much associated with the SVT type of presentations or the atrial fibrillation with rapid ventricular response presentations. Very good. Again, the classical delta wave that you need to be seen, short PR interval, early ventricular depolarization. Here's another example. Does it look like VTAC? Yeah, it kind of looks like VTAC. But then you notice that it is irregularly irregular. Okay? And anytime you see something irregularly irregular with no visible P waves, by definition, we've been saying that's atrial fibrillation. This is how crazy atrial fibrillation is. It can look like VTAC. I mean, you're thinking, this looks like VTAC. But it's really atrial fibrillation with a WPW syndrome, okay? And it's a rapid ventricular response, okay? And these waves are looking this way. It looks like something scary, but this case showed you that they're suspecting WPW. Now look what happens when they slow it down. They DC cardioverted the patient because they were suspecting that this was atrial fibrillation with rapid response. And now we see a more narrow complex QRS pattern, and this QRS pattern was narrow complex as well. Okay, this is not ventricular wide, this is narrow complex. So you're thinking, what the heck is this? This is another look at atrial fibrillation. They slow it down, and when they slow it down, you say, wow, they're back in sinus rhythm. Well, not quite. This is WPW syndrome. See how short the PR interval is? And you may get a slurring of sometimes you get a slurring of the delta wave, but sometimes it's really hard to, you don't get that classic delta wave. But the thing that gives this away is the fact that the PR interval is so short. Okay? In other words, this P wave is not conducting this ventricle. Okay? It can't. The P wave is depolarizing the atria, but the signal bypasses the AV node, and that signal allows for the ventricles to be depolarized through the bundle of Kent, or through the accessory pathway. Okay? This is an EKG that was sent to me by a friend of mine, a little girl who I see as not only as a friend but a patient. And this little girl, I believe, was around 10 years old, and she had palpitations at recess or running around, and short of breath associated with that. What do you think of this? Again, this was WPW, little 10-year-old kid, which was a great little girl, but she has this classical delta wave. And I think this just goes to show you, you've got to be aware of it in kids as well as adults. And I wanted to show you something else. The mom and dad were so worried about the kids' palpitations, they went to the iStore on their iPhone and downloaded this app, which blows my mind, for 99 bucks. And you buy this pad, I think they bought it on Amazon, the product on Amazon, and then they can go to the iStore and download the app that comes with it, and the app on your iPhone connects to this little finger pad, and the finger pad, you put your fingers on it, it will either give you a rhythm strip or it can give you an EKG. I think that is so cool. So the mother and the father bought it. It was delivered in a couple of days off of Amazon. The girl puts her fingers on it and produces this strip, and they send it to me and say, what do you think? Amazing technology that we have today. And it's almost, I mean, I toy with the idea of getting one of these myself, but I just wanted to show you the technology a little bit and how it plays out sometimes, but also just get appreciation for WPW in kids and adults and the association between atrial fibrillation and SVT. She had a lot of SVT in her presentation. Okay, moving on to case number 8. 32-year-old male presents to the ED, sick feeling for the last 6 days. The symptoms include fevers, cough, difficulty catching his breath, past medical history, hyperlipidemia, obesity, and metabolic syndrome. Metabolic syndrome meaning low HDL, high triglycerides, high sugar, high blood pressure, and high weight, obesity. Okay? So you have to have 3 out of 5 for metabolic syndrome. The vital signs look good. But we'll see that the temp Celsius is 38.1, and that's going to correspond to 100.58 or 100.5, almost 101 on the temperature. Blood pressure looks okay, respiration is 22. So the patient looks febrile. Here's the EKG. What do you see? So this EKG shows us that when we kind of look around, looks like we've got ST elevation in lead 1 and AVL. You think, oh, is there an MI? And we see some ST elevation in lead 2, looks like here. Maybe something in AVF in lead 3. We look over here in V4, 5, and 6, maybe some ST elevation here. And we're trying to figure out what's going on here in V1, 2, and 3. So not as pronounced in V1, 2, and 3 as V4, 5, and 6, but and we see it pretty much through the rhythm strips down here. So there's a whole bunch of ST elevation everywhere. You think, is he having a heart attack everywhere? So this is an example of acute pericarditis. So with acute pericarditis, we have diffuse ST elevation with PR segment depression. This is sort of the diagnostic thing. So the causes, again, could be viral, neoplastic, uremic, or connective tissue disorder. The pain is usually relieved as the patient leans forward. It is more pronounced as they are more recumbent. That has to do with the pericardium being inflamed and the heart resting more on the pericardium, leaning forward. Sort of takes a bit of the weight of the heart off the pericardium. So it's associated with a friction rub. The best way for me to describe a friction rub is sometimes if you put you put your stethoscope in your ears and just kind of put it on your chest, but then rub your chest. It's not a very, it's more of a rough, coarse sound. That would be my best way to describe it. No substitute for listening to it on the wards if you have it, but again, if you notice something that has that coarse texture to it, think about acute pericarditis in that finding. And again, it's always a differential with patients with cancer and uremia for sure, and any other type of connective tissue disorder. The PR depression that we'll see, mainly you have to kind of draw a line here and connect the isoelectric lines and just have a feeling. Sometimes it's a visual impression when you look at the EKGs, but just sort of have a visual impression of where the isoelectric lines are. And if it's pretty, if it's pretty reproducible all through here, then you kind of get maybe a visual impression that it's not so much that this is elevated too, but this here, this segment is too low. And so a little bit hard to see and appreciate, but this PR segment is low, as well as this segment is this point is elevated as well. So the EKG findings that we're supposed to appreciate are PR depression and diffuse concave ST elevation. "69-year-old male, case number 9, presents to his cardiologist for outpatient 6 weeks post-hospital visit. Previous hospitalization for non-cardiac chest pain. After the hospital cardiac meds, post-hospital cardiac meds, an ACE inhibitor, a beta blocker, aspirin, and a nitrate. No current complaints." So he's coming in for his 6-week post-hospital visit. No complaints. So here's what you see on the EKG. What do you see? So we see some abnormalities here. And the first thing you see here is something that looks irregular. And we always look for whether it's regular or not, and we look whether it's regularly irregular or irregularly irregular. And in this case, it's irregularly irregular. And we look for our PR intervals. We don't even see reproducible PR intervals as well. We see what looks to be maybe like some old Q waves over here. And we see these, maybe a rabbit ear pattern over here, huh? So what we're supposed to see is atrial fibrillation with irregularly irregular, no visible P waves, a right bundle branch block because we have these rabbit ear R and an R prime pattern in V1, and we see an inferior infarction, okay, because he's had 1 week after his infarction. So we see pathological Q waves setting up shop in the inferior lead. So again, the R prime pattern here that's associated with right bundle branch block, we don't see that pattern in V5 or 6. That's a right bundle. Inferior leads here show these Q waves. Q is greater than 1/3 the height of the R wave. And irregularly irregular, no visible P waves. So we've been able to sort of combine atrial fibrillation, inferior MI, and right bundle branch block into this EKG. Kind of cool. What's going on with atrial fibrillation? Well, again, normally we'll have a depolarization from the SA node to the AV node to the ventricles. That will result in our normal heartbeat down on the bottom left with a nice normal P wave with a narrow QRS. And then over here on the right, we see the example of what the heck is going on with atrial fibrillation. There's a ton of atrial depolarizations going on, and we see irregularly irregular ventricular response. So what's happening is in the atria, there's no real depolarization going on in the atria. It's just fibrillating. In other words, it's just shaking. It's just quivering. And as we said before, it could be 600 to 900 beats per minute in the atria. It's really, really fast. And it's not even anything that of any distinction. It's just a quivering atria. Okay? Now, some of those signals do get down and depolarize the ventricles, and that's why the ventricular response is narrow, because the signal is coming from the atria. If it was coming from the ventricles, it would be wide. But it is coming from the atria, but the ability to get through the AV node is just very, very random because the signals are not even true signals. And that's why the ventricular response can be so varied. Okay, so that being said, we have a rule about atrial fibrillation. From here on out, just commit it to memory. For atrial fibrillation, if the rhythm is irregularly irregular and there are no visible reproducible P waves, then it is atrial fibrillation by definition. And a word to the wise, on our competency exam, you're probably going to see this several times. So in that spirit, let's take a quick look at this as an example of atrial fibrillation. The rhythm is irregularly irregular and there are no visible reproducible P waves. This is definitely something you're going to see on your ACLS. The ventricular response rate it can be fast or slow. So you can't really memorize atrial fibrillation. You just have to rely on this rule. I can't overemphasize this. Look at this. This is another example of atrial fibrillation. The rhythm is irregularly irregular and there are no visible reproducible P waves. We say, well, look up there. There's one. It is irregularly irregular and there are no visible reproducible P waves. Over here, we don't see those P waves. But what you got to appreciate, in this strip, which is a little on the tricky side, this rhythm strip is recorded at a different time than this is up here. So in other words, this is atrial fibrillation, and then it takes over and back into sinus rhythm. This is what this EKG is showing. Atrial fibrillation rhythm here, and then it takes back over into sinus rhythm. Yeah, this one is pretty tricky because you really have to march out these QRSs to prove to yourself that it's irregularly irregular. Let's look at this one, a little bit easier. Irregularly irregular, no visible reproducible P waves. It has to be atrial fibrillation. Here's another example of AFib. We don't see reproducible P waves, and the first thing that always comes to your mind, if you see something irregularly irregular, think about AFib over and over and over. Now this does not look like a standard EKG. It just looks like, because the leads aren't really numbered, they probably have different leads going, but we just don't see the numberings here. But I wonder if this is a patient with a bundle branch block, because we see these big QRS. So it doesn't mean that this is all a ventricular rhythm. This is likely atrial fibrillation with a bundle branch block attached to it. So let's just review just for a second atrial fibrillation, SVT, and atrial flutter. We said last time atrial fibrillation is irregularly irregular with no visible P waves. We said supraventricular tachycardia is really fast and we may not see P waves, but the rhythm is regular. Atrial flutter is really, really fast also, but we see the effects of P waves because this brings, because the flutter rates are going 250 to 350, that brings us into this sawtooth pattern of atrial depolarization. So atrial flutter, this sawtooth pattern, supraventricular tachycardia, and atrial fibrillation that we looked at last time. I could not resist putting this slide in. Sorry, but I just thought it was so interesting to me, and I just wanted to, again, throw a little physiology at you, or just a bigger picture. We say always that atrial fibrillation is sort of a condition sometimes that we see in age. Okay, so these are non-modifiable risk factors. There can be genetic components, gender components, ethnicity components that make people prone to atrial fibrillation. Some modifiable components: physical activity, smoking, obesity, diabetes, sleep apnea, hypertension. These are risk factors for atrial fibrillation. And diseases, heart failure or MI, can make people at risk for atrial fibrillation. So all of these things taken together can contribute to fibrosis of myocardial tissue and slows down the electrical conductivity of that myocardium. And then you throw in the possibility of inflammatory factors, interleukins, measured or tumor necrosis factor, or any type of inflammatory process that oxidizes this tissue. And you have subtle things that make people at risk for it. And so these are just risk factors that I think that whenever we see atrial fibrillation in people, we always want to think back about maybe what their risk factors might be. And it just really helps us as doctors to try to work on these things, because when you combine risk factors with the effects of possible inflammation, we have a myocardium that is primed to deliver atrial fibrillation. And of course, the outcomes of atrial fibrillation might be more things: stroke, more heart failure, MI, dementia, has been associated with AFib, as well as ventricular thrombus. Thought that was an interesting slide. Case number 10. A 79-year-old male brought to the ED via EMS with chest pain, shortness of breath, and near syncope. Past medical history is unobtainable due to the patient distress. Vital signs are okay, but blood pressure is down, 82/40, respiration's 28, and the pulse is in the 140s. Good gracious, what's going on? What do you think's happening here? Is it regular? Yeah, it's regular. Is it narrow complex that would make you think SVT? No, it's not really narrow complex. It's wide. Okay, so we're thinking, well, maybe this is ventricular and fast. This is VTAC. Okay. VTAC could rapidly deteriorate into VFib, or torsade de pointe, asystole, or sudden death. So sustained VTAC is something that is more dangerous. And as we said, our ventricular rhythm, VTAC is 150 to 250. V flutter is 250 to 350, just like our atrial flutter was. And our escape rhythm for the ventricle is 20 to 40. That means if the atria doesn't depolarize, or the ventricles, junctional rhythms don't depolarize, the ventricles will take over. 20 to 40 is idioventricular rhythm. 60 to 130 is accelerated idioventricular rhythm. We looked at those strips last time in part 2. So now we're looking at sustained VTAC, 150 to 250. So as we go back, we see from here to here is 300, 150, that would be 100. So this is about 150 or so. Sustained VTAC going about 150. Why is it wide? Because, again, the origin of the depolarization is occurring in the ventricle. It is not occurring in the bundle of His or Purkinje fibers. If it was, that means the QRS would be narrow. because the bundle of His and Purkinje fibers are very efficient. If it is a ventricular source, that means it's got to spread less efficiently. Therefore, there's more time to depolarize the ventricles than using the electrical conduction system. That's why the rhythm is wide. Case number 11. An 82-year-old female is admitted to acute care hospital due to chest pain, past history, hypertension, diabetes, CHF, obesity, depression. Whole bunch of stuff. Cardiology is planning a cardiac catheterization due to a new finding during the initial consultation. So, chest pain. What's going on? Here's the EKG. All right, we're looking around. It looks regular. Hard to know if I'm seeing P waves. This is kind of a lousy EKG. But I'm seeing QRSs. What was patient has? Did we say the patient has chest pain? Yeah, the patient has chest pain. So now we're looking for, do we see our ST elevations? We don't see ST. There's deep, S waves. So I think we've got our criteria of 25, for left ventricular hypertrophy, right? We see that. AVF is positive, 1 is positive, is normal axis. But what's going on? We're supposed to look over here. So what's this mean? Well, it's big. Is it ventricular, or could it be a bundle branch block? Do we see our RR prime pattern? No. But we see a big QRS over here. What we're supposed to see is a left bundle branch block because it's got a wide QRS. Okay? Now, they're calling this accelerated junctional rhythm. Why? Because there's no P waves. This is a really, really cool EKG. Okay? This is another example of accelerated junctional rhythm. 60 to 100. This is going 75. But the thing that we're supposed to really appreciate, even more than that, is this is a case, this is a no-misser here for us. New left bundle branch block. Okay? This is an example in this clinical case that the patient had new left bundle branch block. Is that a big deal? Yeah, because it's supposed to be a new MI until proven otherwise. And as my note to you, it's our responsibility to differentiate new versus old bundle branch block, okay? Especially in the acute setting. So that's what we have to review for today. This is a bundle branch block pattern, okay, in our V4 through 6 leads, but an ischemic bundle branch block, look how just subtle it is. Okay? It's really hard because the ventricle is slow to depolarize. It's slow to reflect the things that you would normally see without the bundle branch. So in other words, you've got a problem with conduction, and now you've just infarcted that, okay? And if you have a normal bundle branch block, that's one thing. But if you have a normal heart and now we have some damage to the heart, that would cause a bundle branch block too, if we've infarcted the heart and disrupted the bundle. So here's the subtle changes between V1 through 3. Sometimes this S wave can be just a little bit depressed, this ST segment. Okay? Sometimes we might see subtle ST elevation here. And in V1 through 3, sometimes we'll see a little bit of ST elevation here, just a little bit different than the look here. But again, these are so subtle, it's really almost academic to point this out, but the real take-home message is, well, first, we just never want to, in the setting of chest pain, if there's bundle branch block, we can't take it for granted. We always have to double check the status of the bundle branch block. So again, a right bundle branch block, just to review again, R and an R prime, and a broad QRS pattern V6. With the left bundle, deep S wave, kind of pointing to the opposite section, but in this wave, we see in the V6 lead down there on the bottom right, we see the big wide V6, and we see it a little bit sometimes in V5. The big broad R wave. Okay, so the difference between right bundle and left bundle, but we're focusing on the left bundle branch block. So just again, left bundle branch block is an MI, a new MI until proven otherwise. So you should always, if you have a left bundle branch block that you notice on your EKG, and you're checking out to your team, say, I've tried to look for an old EKG and I couldn't find one. So this is a new bundle branch block. You should probably have cardiology see this patient if you can't look at an old EKG. And that's why there's a saying in cardiology sometimes, your best friend is an old EKG. Because if you see a bundle branch block and you don't have it documented in the history that there's an old left bundle branch block, if you can find one from the office or from a previous hospitalization, then you can document that this is an established left bundle branch block. Otherwise, you have something on your differential that you have to prove. Fun facts, I don't know if they're fun, but left bundle branch block is present in about 7% of acute myocardial infarctions. So if your patient has an MI and you have new bundle branch block, make sure you document it. Left bundle branch block increases the risk for mortality when you have an MI. Okay, so it matters because there's enough damage that it has damaged the conduction system in the heart. Okay, and so older age patients with other comorbidities, and as we said as we looked at atrial fibrillation, all those things add up to the health of the myocardial tissue, and that affects conductivity. So there's two settings of left bundle branch block. The happy face and the sad face. The sad face says if you have left bundle branch block on admission and the recent EKGs outpatient are normal, then the patient is presumed to have new onset left bundle branch block. Okay? And you have to say that that is the equivalent of ST elevation until proven otherwise. So when you have a patient coming in and you say, oh, there's chest pain, and there's new bundle branch block and there's no history of it, you better order your troponins, and until you get some clarification, you have to be on highest alert. The second setting of left bundle branch block, as we were saying it another way, if you have a left bundle branch block on arrival to the hospital, and you see previously documented left bundle branch block on previous EKGs or in your problem list, you're okay. That's happy face. There's something called a Saragossa criteria, and it's used in the case of left bundle branch block and suspicion of acute MI. If you have ST elevation of greater than 1 millimeter in the leads, like V5 or 6, you get a score of 5. If there's ST depression greater than 1 millimeter in V1 through 3, you get a score of 3. If there's ST elevation over 5 millimeters in leads, V1 through 3, you get a score of 2. Okay? And if you have a score sum of 3, there's like 90% for detecting MI. Now, this is not going to be on your clinical competency, and this most likely will not be on your boards, and it's probably not going to be on ACLS. I just thought that this was just to show you that there's criteria to try to figure out at some point if the patient is having an MI with this new left bundle branch block. Because you might not see the traditional ST elevation. Why? Because the bundle has been damaged. And this is why you would need to consult cardiology very quickly. So we just wanted to put this in so you could just appreciate the circumstances with which you have to respect left bundle branch block and how important it is to document it in your problem list, in your office problem list or in the hospital problem list. Case number 12. I think we have an even dozen on this one. 59-year-old male presents to the ED diaphoretic and in distress. Past medical history, hypertension, end-stage renal disease, diabetes, and left BKA. Vital signs look okay, but look, the pulse is up and blood pressure is down and there's a little bit of tachypnea happening. Let's take a quick look at the EKG. What do you see? Looks pretty fast. My first thought kind of goes to, whoa, look at this. We're supposed to look at that anyway, so I'm glad. It's pretty tall, isn't it? I think my eyes kind of go over here. What the heck is this? Is this like 2-to-1 conduction? It's like, whoa. Am I dealing with a Mobitz 2? The PR interval's pretty fixed. I'm going to say it's a Mobitz 2. If I did, I'd be wrong. So why is it not a Mobitz 2? Well, sometimes on these EKGs, your eyes kind of go over here, and you can double check yourself somewhere else on the EKG. So if I go up here, that is definitely not the same morphology as that. And if it was, this would be 2 P waves. But this is the T, this has to be the P. And then you can kind of look here and appreciate that does not look like that. That's the T, that's the P, QRS. This T looks like this T, looks like this T, looks like this T. They're all the same. This P looks like this P, looks like this P. They're all the same. And when you go down here in the V5 strip, again, T doesn't look like P, okay? So this is the T. If that's the T, this is the P, and very, very peaked T waves. So this is a example of a peak T wave. And this is a no miss. This is one of the signs of hyperkalemia. My slides might be a little out of sorts here. So what I was doing to plan this for you is I wanted to not only show you a picture of a very, very common non-cardiac cause of EKG abnormalities, but I wanted to throw in some other common non-cardiac related causes of EKG findings as well. And this will be our last case of the day. So I just, like any great presentation, like fireworks, we have to have boom, 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 boom. So I just wanted to give you some boom, 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 boom. A lot of different little examples of things that you could see. Okay, so we'll just jump right in. And this is what I think I was trying to do. P pulmonale is a tall peaked P wave. Okay, and it's generally due to an enlarged right atrium. Okay, and you see that a lot with pulmonary hypertension, lung disease for sure. A biphasic P wave goes up, goes down. Okay, associated with left atrial enlargement. And remember, when you have left atrial enlargement, bigger and bigger and bigger, what's that associated with? That's associated with refractory atrial fibrillation. So you have to be careful about that when you're looking for that left atrial enlargement for whatever reason. And remember, we were saying atrial fibrillation has all these things that kind of lead up to it. Well, this is one of them. Left atrial enlargement for whatever reason. Then we can see evidence of a notched P wave. That's P mitrale. Okay, mitral stenosis can cause P mitrale or left atrial enlargement. But for the boards, I think I've always seen it associated with questions asking about mitral stenosis. So I wanted to throw those in. Okay, so this one, whenever you see something really spiky like this, that is not like some R wave sitting out there. This is not like an RS. This is just a pacemaker spike. This is a single chamber pacemaker spike. Sometimes you'll see one before this, the atrial, like a dual chamber pacemaker. So just be aware that you can see these sharp, thin spikes are very mechanical. Okay, so this is a paced rhythm. Why? Because the pacemaker is firing and it is capturing the ventricular rhythm. Boom, here's torsade de pointe. Oh my goodness. So that is a very specialized form of ventricular tachycardia, and it means twisting of the points. It's very distinctive. The amplitude completely changes, and it's like a twisting of the QRS complex around some isoelectric line. You can't really determine the rate, but in any event, it is associated with a high rate of mortality. You can code at a higher rate with this rhythm. So just wanted to throw that at you. This was my solution slide to our earlier case, the hyperkalemia. So sorry about a little bit out of order there, but we see tall peak T waves in our previous EKG. And just a little bit more of a word about hyperkalemia. Yes, good. Okay, so with hyperkalemia, we can have the peak T waves when we have when we have mild hyperkalemia. And it's usually a little bit of a prolonged PR segment and peak T waves. But as the hyperkalemia increases, we can see first a loss of the P wave, a prolongation of the QRS complex, in other words, that little bundle branch block pattern, as the conduction begins to slow. It's not really that the bundles are blocked, it's just the conduction through the normal, 80 node bundle of his Purkinje fibers is slowing down. And so we're in slow motion, okay? So then severe hyperkalemia, we begin to see huge widening of the QRS complex, much bigger, and we begin to see now ventricular rhythms, bad ventricular rhythms like VFib. So just a word to respect hyperkalemia. And the EKG patterns can look very different. They could show you severe hyperkalemia on boards or mild hyperkalemia. I would bet that you would be looking for this rather than this, because this is, unless they give you like a laboratory finding, you're probably not going to be thinking hyperkalemia. You're going to be thinking like a ventricular, some type of ventricular rhythm. Just a few extras that we'll throw in here just for the final finale. QR interval. This is like, to me, one of the stepchildren. It's like something we don't talk about as much as the general rhythms. I really doubt they're going to ask you to calculate a QR interval, and it's not on our competency exam, so don't worry about that. I just wanted to have a good minute or so discussion about this. The QR interval decreases as the heart rate increases. Okay, so as you get this faster, the interval between the beginning of the Q wave and this interval point of measure at the end of the T wave, or the peak of the T wave, is going to decrease. Okay, why is all this important? Because this is the refractory period for the ventricle. Okay, so this is a point in time that the ventricle is repolarizing, and this is a vulnerable point for the ventricle. So, as a general rule, the QT interval should be 0.35 to 0.45, or less than 2 large squares. Should not be more than half of the interval between adjacent R waves. Okay, shouldn't be too long. Let's take a quick look at maybe how to calculate it. Now, the EKG generally gives you the QR interval, and that's fine. This is really for the type A'ers out there, but if you need to calculate it for some reason, use lead 2. Use lead 5 if you can't read lead 2. Draw a line through the baseline. Here's the baseline. Draw a line. Okay. Preferably the isoelectric line, which is including the PR segment. Boom, there it is. and draw a tangent line against the steepest part of the T wave. Okay, this is the tangent line, and you have to find the steepest part of the T wave. Okay, if the T has two positive deflections, use the tallest one. Okay, so the QT interval starts at the beginning of the QRS. Okay, so here's the beginning of the QRS, right there, and ends where the tangent and the baseline cross. It's supposed to end the tangent and the baseline cross, right there, boom. If the QRS duration is over 120, whatever amount that surpasses 120 should be deducted from the QT. So the QT equals QT minus anything that's over 120. Okay? And then to calculate the rate corrected QT, this is a formula, okay, to correct for the rate. This is the QT interval, the corrected QT. So this is our QT that is measured from the beginning of the Q to this end of the T, divided by the rate. Okay, and that gives us our corrected QT. So this is sort of an example of doing that exact same thing. We get a number here, and basically, if your Q2 is too short or too long, you're going to have more risk for arrhythmias. Certain medications can do this, antiarrhythmics, tricyclics. You can have phenothiazides, electrolyte imbalances, ischemic changes. So in any event, that was just a quick little blurb on calculating QT intervals. We typically don't do it as much. We usually see it on the EKG. The EKG is nice to us in that regard. But you can have these long QT syndromes. I've never seen these, to be perfectly honest, but I wanted to throw them in. And just down at the bottom, we see an example of a normal T wave. Usually less than 2/3 the amplitude of the R wave. So just a quick blurb on that. Sometimes we might see something after our normal looking T wave. We see a little bump there, and that's a U wave, just to point out the little U wave that never gets acknowledged. I've seen it maybe once on the boards, talking about a prominent U wave or something like that. Repolarization of the Purkinje fibers. Not everything, not a lot of cool questions on U waves, but you can see it in hypokalemia. Hypercalcemia, thyrotoxicosis, digitalis epinephrine, some antiarithmetics, as well as congenital long QT syndrome. Okay? So, and I've not really looked for inverted QTs. This slide is talking about those. I've not seen that, or ventricular volume overload. I think that's a very cool association. And in preparation for you, I think it's a cool thing to look for. If you see it on the wards, just save it for a great teaching case. But I don't think you're going to see a lot of that on your boards. But you might see something associated with hypokalemia. So just remember, the peak T waves are hyperkalemia, and then U waves would be hypokalemia, and then hypercalcemia is fair game, I think, to ask you about. Again, we talked about hyperkalemia starting off with peak T waves and then sort of digressing into this sine wave pattern, and U waves being associated with hypokalemia. There is something we talked about. Hypo and hypercalcemia. Short QT has been associated with hypercalcemia, hypocalcemia, long QT interval, for those who may be just wanting to to remember that. But other than that, that's our review. I hope this was helpful to you. Again, look for one main finding, clinical cases usually with EKG, and focus on the common things that you would want to see. So, good luck with your EKG review, and good luck on your competency.